Hi, everyone. My name is Maie St, and it's a pleasure to have this opportunity to speak with you today about some of the work going on in our laboratory. Today, we're going to cover precision surgery, the next leap forward for our patients. First, a little bit about me. I completed my bachelor's in both biology and English at Stanford in 1992. I then attended Yale University School of Medicine, where I completed my MD and PhD degrees through the medical scientist training program funded by the NIH. I then had the opportunity to come to UCLA, where I completed both my internship and residency in general surgery and head and neck surgery, and completed a postdoctoral research fellowship. In 2018, I had the opportunity to complete my certificate in the business of medicine at the Harvard T.H. Chan School of Public Health. I currently hold the Thomas C. Calcaterra Chair in Head and Neck Surgery, and I serve as the chair of the Department of Head and Neck Surgery here at UCLA. I'm a professor in head and neck surgery and bioengineering. I co-direct our UCLA Head and Neck Cancer Program, and I'm the director of the Office of Cancer Training and Education at the Johnson Comprehensive Cancer Center. So we went a little bit over who I am and how I got here, and now I'd like to dive into what I do, followed by a mini summary of our work. The activities in our laboratory are based on a tripod model. We are very interested in innovation and creativity and out-of-the-box thinking as to how we change the future for our patients. We are very interested in collaboration, how we work together across facets at UCLA, throughout the University of California, and all around the globe, thinking together and coming together with our strengths to create a stronger future for our patients. And we're also very devoted to ensuring that our findings become our patients' reality and making an impact for their future. One of the most important goals in our laboratory is to provide better diagnostic and therapeutic modalities for our patients with cancer and make our discoveries their reality. We strive to bring together the bench to bedside abyss and making these translational discoveries become a part of the standard of care and continue to shape the future. How we do what we do is really based on the fact that our laboratory exists at the confluence of surgery, surgical patient care, and engineering. Through this, we are able to combine the human touch, the art of clinical medicine, and it's driven by engineering and science. I'm a head and neck cancer surgeon, and head and neck cancer is the sixth most common cancer in the world. Head and neck cancer affects 65,000 Americans and more than 500,000 people worldwide per year, and still accounts for 300,000 deaths per year. Head and neck cancer affects all the anatomic subsites, including the nasal cavity, the back of the nose or the nasopharynx, the palate, the tongue, the throat or oropharynx, the larynx or voice box, and the trachea leading down to the lungs. The story that I'm going to share with you today is but one of many projects ongoing in our laboratory, but I wanted to share this one today. This story begins when a 32-year-old woman came into my office with her husband because she had been diagnosed with a tongue cancer. She and her husband asked me two very important and salient questions, and they had gone all around the country speaking to practitioners and providers. The first question was, "Doctor, how much of my wife's tongue are you going to remove? Because we do have two young children and she does read them bedtime stories." And the second question was, "Once you remove her tumor, how will you know that in fact you have removed the entirety of the tumor?" Because as we know, surgical margins, or the margins around the tumor, are very important in tumor recurrence and prognosis. Their questions weighed heavily upon me, and I gave them the standard of care answers, but they also encouraged me to work with our wonderful team of engineers here at UCLA to create something better for the future. Now, as far as surgical margins, it's a very delicate balance, especially in the head and neck area. The primary aim of surgical management of head and neck cancers, as with all solid cancers, is complete resection of the tumor in order to ascertain negative margins. If one is able to get all around the tumor with negative margins, as opposed to cutting through a tumor, leaving a positive margin, this has important consequences. You see, positive margins increase local recurrence and mortality for these patients by 90%. Additionally, over-resecting healthy tissue, whether it be tongue or the voice box, of course will increase patient morbidity and affect their potential speech, swallow, and altering their appearance, which of course leads to a decreased quality of life. So the single most important prognostic factor in this presentation is that there is complete surgical removal of the neoplasm. Even if microscopic cancer is present at the margin of the resection, it increases local recurrence and decreases survival. And currently, the only tool that we use to assess margins is the surgeon's fingers in clinical judgment, followed by sampling some frozen sections, which of course may be subject to a geographical miss of areas that did have positive cancer. So when we think about the gap in this area and what we can do for our patients, what do we need? We ultimately need a tool that can cut, that can coagulate, and can provide us real-time intraoperative information and feedback as to the proximity to cancer and cancer cells. So working together here as a group at UCLA in our laboratory, we have developed at UCLA an advanced optical technology to discriminate cancer tissue and tissue margins, and we have termed this dynamic optical contrast imaging. Dynamic optical contrast imaging, or DOSI as we call it, is a non-invasive imaging system that captures endogenous decay rates using a high-speed camera. It's important to note that DOSI is label-free and does not involve any injection of contrast agents. The only light excitation source is UVA, and the emissions are passed through 9 channels. The images are acquired in real time in approximately 5 seconds only per channel, and the operative field is relevant in that the field of view is up to 6.5 centimeters squared. In DOSI, we pump the samples or tissue with short excitation pulses. We then are able to generate contrast with lifetime measurements, but we avoid lifetime extractions or computations. This allows DOSI to be different from other lifetime fluorescence techniques, and we have improved robustness to clutter, including blood in the field. It's ideal for in vivo imaging, and we provide maximum contrast generation in clinically relevant fields and time. We first started out by looking at ex vivo specimens, and one of the things that's very important to us, and in fact very important to DOSI as an imaging modality, is that we are able to detect these margins and completely have them be congruent to histology. There are many imaging modalities on the market that have not been vetted closely with histology, but here in our studies, we have looked at histology as the gold standard. And as you can see in these images, we take the gross specimen, we look at it by histology with our pathologists in a blinded fashion, and then we compare the DOSI images, and we have been able to validate that DOSI can distinguish cancer areas from fat, epithelial tissue, and connective tissue in the surrounding areas. Using DOSI, we've been able to come up with a signature or a fingerprint for each tissue type and provide discrimination intraoperatively. Here are images of a patient that had a tumor in his tongue. We see what the light image, the RGB image shows, and then we look across wavelengths at DOSI, and we're able to precisely see the edge of the cancer, allowing for precision surgery and better outcomes for our patients. Additionally, I want to bring your attention to the fact that DOSI is also able to identify and discriminate perineural involvement of cancer. When small cancer cells can travel across the nerves, this can lead to a positive margin along the nerve. Intraoperatively, if we just look at the white light images, we may not always be able to tell where there might be cancer in the nerve versus inflammation. DOSI allows us to see, if you look at these gray arrowheads, early tumor infiltration into the nerve, because removing a nerve from these patients can have very important morbidity and consequences to quality of life. Additionally, how do we screen patients? When patients come into the clinic with a white lesion on their tongue, how do we know it is a tumor? Currently, biopsies are performed, but of course, these are invasive, and sometimes you can have a geographic miss if the anterior portion is biopsied, but there may be depth differences in the posterior area. Using DOSI, we can take these images using the DOSI camera to look at cancer versus inflammation. And this, of course, would be fantastic in terms of screening for these patients and preventing the formation of invasive cancer. So DOSI, as you can see, is a label-free modality, does not involve the use of any contrast agents, and images are generated in real time, providing the surgeon with an easy-to-interpret, color-coded map of the surgical field. DOSI is used intraoperatively in vivo to distinguish healthy tissue from malignant lesions, and it can detect perineural invasion that is not grossly visible by white light imaging. All of this, of course, is very exciting to us and occurred because of the generosity and funding of the National Cancer Institute, the National Institute of Biomedical Engineering and Biomedical Imaging and Engineering, and we were also very fortunate to be recipients of the Innovation Fund. So what opportunities are out there and thinking about precision surgery and the next leaps forward for our patients? My patients inspire me. We have a challenge here for the oral and head and neck cancer patients and for cancer patients all throughout. We have to think about function, the impact on their lives, and we have to do better. For the future, we know that the end of cancer begins with research and multidisciplinary clinical translation. We want to make these ideas a reality for all patients across the globe. We have strong collaborations, and we continue to support the goal of providing better diagnostic and therapeutic modalities as we shape the future for our head and neck cancer patients. It's been my pleasure to speak to you today about one of many projects in our laboratory. We hope that we can continue to partner with you. Please reach out, and I thank you very much for your time and attention.